And David, so we've moved now to this IPI salvage slide.
Yep.
Overall, I think it's fair to say the data for IPI salvage isn't great, with response rates between 10 and 20%. There'll always be some responders, and a little bit's dependent on, even if you re-challenge with single-agent immune checkpoint inhibition, I suspect after a gap there'd be some responses. What's your take on this re-challenge? Is this convincing for you? And if patients were to progress after that year interval where we agree we are going to re-challenge, should you be re-challenging with axi-pembro, VEGF-TKI IO, or ipi-nivo?
Yeah, so once again, I think we need to be careful with our language. To me, this isn't necessarily re-challenge. These studies are all slightly different. Oftentimes, it's adding ipi when the response was insufficient, as opposed to someone who's refractory to PD-1. But the bottom line is, if the goal is to try to create a remission of the disease, and you believe immune therapy can do that, well, here you have activity in multiple trials of CTLA-4, admittedly, 10, 15, maybe 20% response rate, not great. No one's claiming it's great, but it's better than zero. So
do you think these people are in remission? This CR rate of 3.0 and 2?
They see, right, not all patients in remission need to get a CR, but there are some there. And to me, this is the kind of thing that suggests there's more that you can wring out of the immune response by adding other agents that enhance the immune response to the tumor. I'm not so much pro CTLA-4 as I am pro testing immune therapies in patients who are having an insufficient response to PD-1. To me, that's the window of opportunity. It's not necessarily when they progressed or they're symptomatically progressed post PD-1. When they're having insufficient response, adding novel agents in that place, you could see activity. In this case, you do see activity in multiple trials. So to me, if you're trying to decide evidence-based what you should give after PD-1 failure in the adjuvant setting, the only approach with any data right now for an IO agent is CTLA-4.
David, do you think the response rate would be higher for cabo-nivo or ipi-nivo?
I think it could be. It's certainly all driven by the VEGF.
But so
that's the point, right? It's all driven by the VEGF.
Yeah. You can get to. I'm not anti-VEGF.
No.
But if you look, David, if you just look at these bottom three rows of green, forget that it's ipi or another immune agent, would you think that drug has activity?
Yes.
63% PD rate. 11% response
But the activity is measured in the responses, which are not
CR.
zero. I mean, that kicks ass over everolimus, for God's sakes, and we just did a phase 3 trial.
We don't love everolimus.
I understand, but it's FDA approved, for God's sakes.
Grab a microphone, because we're going to ask some questions about the audience. I know, Hans, you've got an opinion on this, and I'm keen to hear what it is.
Well, I think David is right. So first of all, 15-20%, why are we belittling this, right? There are other cancers who will be excited to have a 15-20% response rate to any form of immunotherapy. So I think we are blessed that there is another option. I think all of us have patients who have subsequently responded. You don't need to have a CR to respond durably from immunotherapy. Again, we need more data in that space. This is a small subset of patients, but I do think it's the right approach. And I don't have a problem with a high PD rate in carefully selected patients. Obviously, patients who are highly symptomatic with a large disease burden, you want to go with the VEGF-TKI. But there are many more patients than that who actually can play another time with immunotherapy.
And Hans, how do you reply to the fact that the response rate with cabo-nivo is going to be 40%?
Well, it's cabo response rate. I mean, I don't care about cabo-nivo. You can use cabo, you can use your favorite VEGF-TKI.
So I mean that, any VEGF-TKI, whatever it might be.
They're purely palliative in nature. The question is, can we induce durable responses in these patients who've progressed on PD-1? That is the goal, right? The goal is cure, not palliation.
But it's not clear that we're achieving that cure here. Let's go with Tian. Tian, I want to hear what your approach is to this patient. Let's say they're 75-year-old, year of adjuvant pembrolizumab, relapsed with 6 lung metastasis, exactly a year after. It makes them essentially, because it's a year after, they're an IDMC good risk patient. What's your treatment you're going to give a good risk patient lapsing a year after?
So that particular situation, we would talk about all of the frontline options. I think what makes us uncomfortable, right, as oncologists and as talking with our patients is this, don't know who is in that 14 to 20%, responses to salvage IPI. So I think IPI-NIVO is an option. But for the person who is like, I need to see my thing shrink and I want the best chance of seeing my target lesion shrink, then I'm not comfortable with that primary PD rate that Brian brought up. And so in those cases, then we're turning to our VEGF-IOs.
Tony?
The one thing I would love to see that will never happen, IPI 1 mg per kg single agent activity as a benchmark. I'm not sure I totally agree with Mike on PD-1 plus another drug. I do believe that there is a chance that the nivo-IPI activity in fraction RCC, and fraction RCC is a study post-PD-1, post-PD-L1 that showed 17% PR durable, published in JITC, which is different than untreated patient of the 42%. But I would argue, until proven otherwise, that the 17% is driven by IPI 1 mg per kg only, without PD-1. No one gonna do that study, certainly not BMS, where's Mario? But I would love to. I would love to be proven wrong. So I think we are giving nivo wrongly here.
So we're just gonna round this up, if I may. Before we round it up, I do want to ask four of you, starting with you, Brian.
Mike agrees.
So you've got a 75-year-old man or woman, a year of pembro, exactly a year off. They relapsed with 6 lung metastasis. They're IMDC, good risk disease. What are you giving them?
I think my default would be Cabo.
Single agent Cabo. Tony.
Single agent Cabo.
Tian.
I would talk about goals of treatment. And if their goal is to get to some durable responses, I'm not opposed to IPI-NIVO. If their goal is to shrink, then I would give a VEGF and possibly a VEGF-IO.
A VEGF-IO, and I'm going to Google VEGF-TKI. And David, tell us the good news.
I completely agree with Dr. Zhang, as always.
Okay.
So 75-year-old, to me, that means nothing. Someone who lives to 75 is going to live a lot longer. The question is, how do they want to spend their time? Do they want to spend their time with a small chance of a durable benefit off drug, or do they want to spend it every day taking a pill that makes them feel crappy? So that's a choice. Or wait to take the pill that makes you feel crappy after you try CTLA-4 for a few months.
We're not anti-TKI. Do we
I'm
know,
not
and
anti,
I'm asking Mike and
just
everyone, you guys keep talking about, there's durable chance of response. Do we know, are any of these patients in durable response? Has that ever been published?
So the fraction are durable so far.
Durable
after
meaning?
like 3 years, PR. Most of them, there was 9. Most of them, 8 are durable. But I would argue it's IPI only doing the trick. Mike, sorry. I know I could be wrong, but someone has to do that.
It's not a question. To me, it's not a question of either or. It's a question, as Tian said, of what right sequence. So give them a second shot at IO and talk to them about clinical trials. And that's the window where we can be doing clinical trials with novel agents.
I'm going to summarize this in a second, but Mike, I can see you burning on your hand on the microphone there.
So, Tony, that trial was done in melanoma, nivo-IPI versus IPI in the second line after anti-PD-1, and there was a 28% response rate for the combination and 11% response rate for single-agent IPI. So in order to keep the T cells active, you need to keep PD-1 blocked. And in every combination with immune therapy, or in every novel immune therapy, it's probably going to be better if it truly activates the T cells to keep PD-1 pathway blocked.
That's the only example where maybe there is synergy.
That's the only example, period.
But it is in the most immune sensitive cancer. It's in melanoma.
With single agent CTLA-4.
I'm really anxious about translating melanoma results elsewhere. I'm just, having spent a lot of time trying to do that in our lives in a whole string of tumors, it hasn't been a successful strategy. And so when you don't know the answer, assuming melanoma is going to be the same as bladder cancer, kidney cancer, or head and neck cancer would be a mistake, in my opinion. I'm going to summarize. David, you're going to say something. I can see you dying to. I want to try and round this up. I'm dying to round this up.
Dying is a strong word, but you say this a lot, and it's hard to argue that you're wrong that different tumor types have different responses to immune therapy. But essentially, what we're trying to get across is we're treating the immune cells here, and those immune cells are going to react to these drugs in patients pretty similarly, regardless of the tumor type.
So I think in summary,
It doesn't mean this effect is going to be the same, but the principles are the same. So we're arguing
I'm going to let you go with this.
No, I don't agree. CD8 high is good everywhere except in renal.
Okay, so
I've lost control.
Well, I've lost control. It's the worst chairing session ever. In summary, then, we're not super keen on Rechallenge with PD-1 therapy in metastatic disease. There is some discussion about late relapses, but then as a group, we don't feel it's a great idea. However, in the adjuvant setting, with that year gap, we seem to be more comfortable for reasons that remain unclear to me. Nevertheless, particularly changing from PD-1 to PD-1 CTLA-4 seemed to have more appetite than Rechallenge with PD-1 alone, and there weren't many people in our panel who wanted to give VEGF-TKI IO combinations. It's either Cabo or another VEGF-TKI or something slightly eccentric with ipi-nivo.
Yeah, it's sensible because there's some preliminary data. But so are you saying that you're going to hold yourself in the bladder cancer world to the same standards?
Oh, here we go.
We should have that
we can
debate.
just eliminate a whole
15 minutes over time.
We're over time. That question is coming up. We're having a third attempt to answer that question at our meeting. Thank you very much, everyone. See you soon.